Today's program and interview is going to be more male-focused than female. Now, I don't want to scare the ladies off because this is a conversation they need to hear as well because it concerns their fathers, their husbands, and their brothers. And that's the issue of prostate cancer, bladder cancer, kidney, and testicular cancer. Right now at Northwestern Medicine's urology program up in Illinois, they've got some exciting news about a new study that's going on. They've got this fund of $10 million that has been gifted to them to create this new institute that's going on and this new study when it comes to cancer and when it comes to urology. And we have the head of the department on the phone with us, the chief of urology at Northwestern, Dr. Edward Schaefer, online with us this morning to talk about not only the research going on, but to talk about the diseases and, well, what's causing the disease, how can doctors test it, and is there anything you can do for a home test when it comes to cancers of that area of the body? And doctor, before we even get started here, I got to tell you, I'm a male in my mid-50s. I go through an exam once a year with my doctor because there is a history of prostate cancer, both with my dad and several of my uncles. So when you tell a doctor that, when you're going over your medical history, their ears immediately pick up. And that's one thing they really look at once you tell them there's a history in the family is prostate cancer. When it comes to these cancers, doctor, is it just detectable through the blood work? Because I do several different tests for the doctor.
Yeah, those are great questions. And when a doctor sees a patient, they look at it and think about a couple of things. One is their age. So you're of the right age to think about prostate cancer screening. And the other is their family history. And that's actually the most powerful thing a patient can do is keep track of what's happened to them and what's happened to their parents and their siblings and their aunts and uncles. And so we think about family history, not only of prostate cancer, so first-degree relatives with prostate cancer, but also family history of breast and ovarian cancer. And when we interview patients, those are keen on our mind. If an individual is over the age of 50 to 55, and for sure if they have a family history of prostate, breast, or ovarian cancer, most doctors would recommend screening, and certainly the patient has to agree to that. And screening involves a blood test. It's called a PSA blood test, and it also involves an exam. It's a rectal exam. Us doctors don't like doing it. Patients don't like getting it, but it's important because that's how we can actually feel the prostate, and we can feel if there's any abnormalities, any roughness or coarseness in the prostate that can be could potentially change our recommendations about next steps for that particular patient.
Now, doctor, don't laugh, but my doctor, my GP, has a great sense of humor, and anytime I see the glove, I say, oh, it's Dr. Jellyfinger, and I know what's coming. So I've already been through that when you talked about the rectal exam, and doctors don't like to do it. But it's also, as you mentioned, the PSA test, and that is something else that is including in my yearly blood work that I go through the doctor. Now, most likely, will the doctor look at that PSA test before he decides to do the rectal exam?
No, they go hand in hand. And so, we do typically do the blood work. You want to do the blood work before you get the blood test because a rectal exam can sometimes cause a bump up in the PSA test. But you want to do both at the same sitting. Most of the time, the rectal exam is normal. And most of the time, the PSA test is normal. But as you alluded to in your intro, the other really important thing is to track your blood test scores year over year. So I want to know, has your PSA blood test changed? And if it's changed, how much has it gone up? Or sometimes has it gone down? Because if it's trending up, so if it's changing, 1 point a year or half a point a year consistently over 2 or 3 years, that may be a warning sign to a doctor, even if the overall number itself is quote unquote normal. I mean, that makes good sense. Just like we check your cholesterol every year, and if your cholesterol is trending up, we're going to say maybe we should put you on a medication. And if your PSA blood test is trending up, then maybe we want to do a biopsy, which would be the next phase. Or sometimes we would do an MRI of the prostate as the next step. So I think, understanding your family history, keeping track of your lab values, tracking everything over time is a way that an individual listener out there can really keep on top of their own personal health. So doctors, our goal is to keep everybody healthy. But certainly if it's the goal of the patient and the doctor to keep them healthy, that goes a long way too.
Now, I kind of flunked biology in school, and it wasn't my favorite topic. But when you're talking about the prostate, am I correct in describing it so our listeners have an idea of what we're talking about? It's basically, I think, the size of a peach pit, isn't it? And it's in the lower extremities. We don't want to get into technical jargon, but is that correct?
Yeah, the prostate, I always tell people it's the size of a golf ball, since most men know what that is. It's the size of a golf ball. It sits just below the bladder, and it's a sexual gland. It actually makes the semen that comes out of the tip of the penis when somebody ejaculates. So it actually has a role in reproduction, but later in life, it doesn't really have a lot of function. But it can cause a lot of problems for men. It can block off their urine flow. Most of the time, that's not from a cancer. That's just because it's overgrown. And in fact, 75% of men over the age of 50 have urinary blockage issues. And it's the leading most commonly diagnosed cancer in men. So we like to say it's a small gland with a lot of problems.
Absolutely. And you brought up an important point here. As we know, we talked earlier that most likely the prostate issues are going to hit in your mid-50s, and especially if there is a history in the family. But you mentioned that that does stop the flow of the semen, that we need to create babies. And we do know prostate cancer has shown up in younger men. So if we've got young men that are ready to start a family, this is something they need to think about. They don't need to think about waiting till their 50s. If there's a history in the family, wouldn't you think earlier if you're going to start having kids?
Yes. So if you have a family history of prostate cancer, breast cancer, ovarian cancer, or if you're African American, then you should begin your screening at age 40. If you are screened at age 40 and we pick up an early cancer that needs to be treated, then we need to think about and talk about with our patients fertility preservation. And there's a whole specialty. We have a urologic cancer institute here at Northwestern Medicine, and part of that institute is designed to provide comprehensive care for our patients. That includes preserving the ability to have children. And so we have a very well-developed, comprehensive way to ensure that individuals who are cancer patients can still have kids after their cancer treatment, not just prostate, but other kinds of cancer. So we have some really special things going on here that are important, and that's just one good example of that. So just because you have a cancer diagnosis doesn't mean your life is over. Our goal of our Urologic Cancer Institute is really to provide comprehensive care for recovery and survivorship as well.
Absolutely. And just real quickly, wrapping up on the prostate before we quickly go over bladder, kidney, and testicular cancer and what you're going to do with this $10 million gift up there. The prostate cancer, I know a lot of people do say, and a lot of people in the medical community, it's one of the most successful cancers to treat. And I know when my father was going through it, the best way I could describe it is it's called a seeding program, where they seeded the prostate, and then I guess the treatment was time released into his body.
That's right. So there's a lot of ways to treat prostate cancer, and it depends if it's localized or if it's spread. Most prostate cancers today are picked up when they're localized, which is good for the patients. Only about 5% are picked up initially when it's already spread throughout the body. And that's just because we do a good job of screening things now. If the prostate cancer is localized, there's a couple different options for patients. We now recognize that about 1/3 of localized prostate cancers may not even need immediate treatment. They're so tiny and slow growing that they don't need treatment right away. And we recommend surveillance for those patients. Additionally, if a patient has a localized cancer that's more aggressive, then we would recommend treatment with either surgical removal, treatment with external radiation that's focused on the prostate, or you can also put in radioactive little seeds that actually, as you say, leach out or emit radiation for about 120 days. So there's a lot of new ways, very sophisticated, fancy ways with robotics and advanced imaging to treat prostate cancer. So we have a tremendous set of tools at our hand, to handle this disease. And with that, in part, our outcomes from it are really excellent.
All right, let's move on here, and we do want to reiterate that it's quality of life we always talk about when we do like these medical interviews. And it sounds like if you're diagnosed with prostate cancer, and this is from what I'm hearing from the doctor, treatment is relatively easy, and it's like the appendix. You can live without the prostate, but if you're thinking about raising a family, please talk to your family doctor. All right, bladder, kidney, and testicular cancer, all these kind of go hand in hand, don't they, doctor, since they're in the same block, the same real estate area?
They are. So we're specialists in urologic cancers, and the urologic organs are the kidney, the bladder, the testicles, the prostate. And so that's what we focus on. Now, bladder cancer and kidney cancer can affect both men and women. It preferentially affects men more than women. So men are more likely to get bladder cancer as our kidney cancer, but it can affect both. And so in our clinics, we see patients, both men and women, who have kidney and bladder cancer. Bladder cancer generally presents with symptoms. It presents with blood in the urine. So blood in the urine, if it was going to be associated with the cancer, which it can be, it's more often bladder cancer than prostate cancer, but it could be bladder, prostate, or kidney. So if you have that, you definitely need to go see your urologist. Now, other signs and symptoms of bladder cancer, associations of bladder cancer, are really exposure. So we know that smoking causes lung cancer and it causes bladder cancer. So people who are heavy smokers, who have blood in their urine, they got to go to their doctor like yesterday to get checked out. Kidney cancers typically are picked up with imaging because of maybe pain in your upper abdomen, of your upper back. Rarely will you have some blood in your urine. And so kidney cancers, again, will present it more when they're larger than a prostate cancer because they typically will present with some kind of symptom. Sometimes a patient will get scanned because their back hurts. They'll get a CAT scan or an MRI scan, and we'll pick up a small kidney mass. And so, that also happens within kidney, that these tumors are picked up while they're small. And so, patients in general, I think going to your doctor once a year, getting a routine physical, getting an examination will help really pick up these cancers while they're still early. And if you have symptoms, you should let your doctor know. Blood in the urine, pain, those kind of things.
And moving on here to testicular cancer, is that done through blood work as well, as we talked about earlier with the prostate?
Yeah, we think about testicular cancer like breast cancer in women. The way that it's picked up most often is by self-examination. So testicular cancer is the most common cancer diagnosed in men under the age of 40. And once boys go through puberty and they're in their mid to late teens, they really should do examinations of their testicle when they're in the shower, and they should kind of just get familiar with their testes. It sounds kind of funny, but it's true. And really, self-examination is the best way to pick up testicular mass. If there's anything that feels abnormal, then they should consult with their doctor. If one of your listeners out there doesn't understand or doesn't know how to do a testicular exam, the next time they go to their primary care doc, they should say, "Hey, can you teach me how to do this?" And generally, we recommend doing the exam, once a month, once every 3 months, and checking sure that there's no abnormalities.
Well, you mentioned it kind of compares to what women do when they do the self-breast exam, and you always say, you hear, she felt a lump, and went to the doctor. Is that what we're looking for as men? We're feeling for what kind of lump? Where would we find it?
It would be in the testicle, which is in the scrotum, and the testicle is generally smooth. And so if you feel a lump, it'd be like a little pea-sized nodule kind of bulging off the side. And that would be a sign that something's going on. Now, testicular cancer is very rare, much less common than breast cancer in women. But again, it's the most common cancer in men under the age of 40, so you can't ignore it. And doing self-examination is the recommended way to pick it up.
All right, doctor, our time is running real short here, and I'm keeping you longer than I promised I would. But I did want to get into this $10 million gift that you received up at Northwestern Medicine up in Illinois, one of the top-rated facilities in the country when you look up online. And Dr. Edward Schaefer is the chief of urology at Northwestern. This $10 million you got, what are you going to do with this? What's the plan?
Well, the plan is to really augment the care that we deliver for our patients right now. So Northwestern Medicine does a great job taking care of our urologic cancer patients. We want to augment that, provide more resources and a more kind of a more centralized location for our patients. And we also want to use the resources to really accelerate our research program. So we're always looking for newer cures, faster cures, better cures. And so part of the resources is really designed to fuel our research infrastructure. We have the second largest research program in the country for urology. And so it's also designed to kind of accelerate that. So what we think we're giving our patients is state-of-the-art care for the individual patient, but we're also thinking about the patients that are 5 and 10 and 15 years down the road, working on better ways to cure them as well.
And is there a website we can check out for further information or to learn more about these type of cancers that you and I talked about?
Absolutely. So Northwestern Medicine has a great webpage. It's www.nm.org. And if you want to find our Urologic Cancer Institute, you would go to www.nm.org/Polsky. Michael Polsky is the generous donor who helped make this happen.